he started using opiates, pills, and then he says by the time like 34, 35, he was using injectables. He found out probably at around age 40 that he had hepatitis C, didn't do anything about it for years. Little over a year ago, he started seeing an infectious disease doctor to get treatment, and then somehow that did not, I don't know, if he didn't follow up or what happened there. So he was referred to get treatment here. He has no apparent problems that he was aware of in terms of liver issues, no pain, jaundice, those sort of things. He's had his hepatitis A and B vaccinations. His past medical history, other than the opiate, is mainly significant for bipolar disorder, and the majority of his medications reflect that for mental health. His labs, slightly elevated liver transaminases, platelets little low at 133. Again, no jaundice, no ascites, normal renal function, APRI at 0.9, child Turco-Pugh class A, MELD score of 8. He was HCV genotype 1A, negative for HIV. All of his hepatitis B and A stuff was normal, negative. His hepatitis C fibrosis marker was a F3, and we were able to track down. I had asked him when he saw this infectious disease doctor if he had done any imaging, and he was like, I think he did. So we were able to track down from March 30th of 2021 a FibroScan, which I don't have, I think, on this report because we just got it. And at that time, a year ago, it said mild fibrosis F1 with severe steatosis S3. So I would like to get him treated epclusa, I would figure with his Medicaid plan would be my options. And then, we can get, based on his other meds, if anybody has any problems, and he probably will need long-term HCC screening because he does seem to have some fibrosis markers. That's it.
Excellent. Thank you so much, Dr. Fournier. Great case there. Before we get into the recommendations and feedback, did anyone have any clarifying questions or comments about the case? And everyone's welcome to chime in, unmute, or chatting in. All right, and any hub members with some recommendations and feedback for Dr. Fournier? Dr. Gilchrist, I see you unmuted.
Yeah, hey Rachel, I'll let you take a swing at the drug interactions because I don't even know some of those medicines. I'm assuming they're some of the psych meds. But Dr. Fournier, your conclusions and everything were perfect. Love where your brain went on it. The middle of the road biomarkers, really kind of confusing. You've got your APRI that's saying probably not cirrhotic, but it's got a lot of scar tissue. You've got your FibroSure that says probably a lot of scar tissue, but not cirrhotic. And then you have your elastography that does not suggest much is going on from the way of a ton of scar tissue. One of the things you can do in middle of the road cases like this is remember the APRI and the serum fibrosis biomarkers place a great emphasis on the AST and ALT, and those will probably normalize fairly quickly as you treat the patient. And given that those are the only two markers that are sort of making you need to do long-term HCC screening, you could maybe, rather than commit this guy to life to that, do it for a few years and normalize his fibrosure and see what happens. Because then you'd be like, oh heck, he doesn't actually have a lot of scar tissue. It's the scar tissue that's oncogenic. And remember, your fibrosure and your APRI are just best guesses. They're best guesses, but they are dependent. They're dependent markers on other tests. So if you normalize some of those, life is going to look better. I'm really comforted by his elastography. That's really, it's interesting. He's got so much fat in the liver. He's a skinny man.
He is a thin guy. Yeah, I was surprised because I just actually was able to see that report today, and that's what they had wrote. So
that's pretty awesome. And it might even be worth chasing that one down in a couple of years too. Just again, just one more. And then, if you cure him and his fibrosure and APRI and everything are normal, and he's got one more elastography that looks great, I think I'd give up on the HCC long term. You're sort of obligated to do it for a little while, but yeah, he's in the middle of the road. His 133 platelet count is kind of like, I think that's also hurting his APRI and his calculations, but it's a interesting case. I don't know all the drugs, so I defer that to Rachel.
Sure thing. So one clarifying question I have, is he taking both the Abilify and the Rexulti?
Apparently. So, I mean, I'm not his behavioral health provider, but that is
okay. They're just both antipsychotics, and I'm not up to snuff on the psych meds and really those guidelines. I don't usually see them together, but that really doesn't
I don't
mean anything. Okay. From a drug interaction standpoint, the only issue would be if you would do Mavorite and Abilify, and it's just a monitoring thing. So the Mavorite, that protease inhibitor, can actually increase the aripiprazole concentration. So because it's already kind of a narrow therapeutic window there for those, puts them at increased risk for those sort of side effects. So, CNS depression, and I don't know if he has if you've got a recent EKG or something, if you have concerns about QT prolongation in that situation. That being said, we have used Mavorite with patients on Abilify with no issues, just counseling them, making sure they know what to look for in those instances. But it's not a contraindication. It's just something we monitor for, and that's specific to Mavorite. I don't have concerns with interactions with the Epclusa.
Okay. That might just be the better way to go then, but thank you for that.
Sure.
Thank you all so much for the recommendations and feedback. Any other comments from anyone with feedback and recommendations? And Dr. Fournier, did you have any other questions you wanted to have addressed about your case?
No, I'm good. Thank you.
Excellent. Well, thank you so much. We really appreciate it. Robin, I have your case ready to go next. If you're also ready to go ahead and present, I'll just pull that up for you. And just let me know when to scroll up or down. Thank you.
I'm sorry, I'm not very good about following what you put on the screen. I'll try to follow the screen better this time. Okay. Okay, so this young man, a 34-year-old male who has he has a history of IV drug use. He's currently in a program here at Southern Highlands. He's been clean since November of 2021. He started using drugs at age 16, and then by 21 was using IV drugs. So the first he knew of his diagnosis of Hep C was July of 2021, which was here with me. His current partner has hepatitis C as well, and I have talked to him about the fact that she needs treatment as well, and he has assured me that they're in that process. So looking at his labs, the abnormal values on his CBC and the CMP include a low platelet count of 80. His proton was okay. His liver enzymes are a little bit elevated. His APRI score He does have some scarring and fibrosis with an average score of 2.594. The child Turco-Pugh score was a B, so his score was 7. And his MELD score was 7. So I'm thinking with that, he probably is going to need that reassessed at least about every 6 months. He did have, I did the original viral load several months ago. I think he went to jail for a short while, so he missed out on treatment the first go round, but he still was clean when he came back out of jail. So the next viral load that I did, I think what you all have on there is the 2,300,000. This last viral load I did was 1,330,000. His fibrosis biomarker was 0.67 initially, and then I repeated it on March the 1st, and it's 0.59. So he's at an F3. You know, I plan with his medications. I feel like I need to probably stop the Imodium, because I feel like at one point you all might have mentioned, I'm sorry, I'm all over the place with that. Yeah, I feel like I need to probably stop that Imodium. I think that it can cause some issues or an interaction. I just need to double check with that, but I think that's probably just something he takes PRN. And then I'm going to add vitamin D. His vitamin D was in a normal range, but I think I need to try to get that above 60. And then what my plan is going to be for him is to, after we get him treated, is to follow up with GI. Since he does have a little bit of fibrosis, I feel like he probably needs GI on board. And so I think he'll probably need a repeat ultrasound in about 6 months. So I'm thinking Mavorite for this fella with his genotype 3 and for 8 weeks. And so I just needed to know if that's an appropriate treatment plan and if that's something I need to follow up with or just follow through with.
Awesome. Thank you so much, Robin. Great case. And don't apologize for going up and down. That's what I'm here for. So
I'm sorry.
No, not at all. Thank you. So any clarifying questions from the group or comments, feel free to unmute. I think Elizabeth chatted in as well. We love to hear from everyone. So don't be shy. We're kind and we're friendly. So
I just had a question. So the ultrasound report is not on the form, or you have that?
I've got an ultrasound report, and it did show he has some minimal non-uniform hepatic echotexture. It says no focal hepatic lesions or abnormal intrahepatic biliary dilation seen. So it wasn't terrible. So and I don't know if you think I need to follow up with an ultrasound, since what I was looking at was his fibrosis score. Is that something I need to do?
Absolutely. Yeah. No, I'm actually really worried about this guy. There's a bunch of stuff on his case that's concerning. You know, it's weird. He's a young guy, but you know, 15 years of genotype 3 can do it. And his platelet count is bizarrely low, really kind of implying that he's got kind of bad cirrhosis. And you have no wonderful treatment option in this guy without a little bit of concern in 2 different ways. And I'll tell you what I mean by that. So obviously, if he really is a child, and I didn't do the calculation, but if he's a child's B, you start sweating the protease inhibitors a little bit. So Mavorite, you start worrying, you got to monitor people a lot more. You got to just watch his liver enzymes, make sure you don't cause problems. Issue with the Epclusa in that scenario, if he's cirrhotic, you need to do resistance testing ahead of time. And so I'm honestly on the side of just giving him Mavorite and maybe watching his liver enzymes. That's all I think I would do. I'd give Mavorite 8 weeks. I think there's wisdom to what you chose. I've been waiting a long time for a genotype 3 with cirrhosis to show up. Mitra and Elizabeth, do I have like 5 minutes to share a PowerPoint? It's literally like 2 slides, 3 slides.
absolutely,
It's
of
just
course.
it's better than me. If I can do the share screen thing?
Sure.
Because otherwise I'll mumble through this thing. So
No, you're perfectly fine.
all right, I
That's
promise
perfect.
not to take up a lot of time. But so the issue, when do we have to do resistance testing? By the way, it's only 2 situations. So what the heck? This is, remember, our drugs. These are our drugs here. And I can never remember the generics versus the brands, whatever. But anyway, what you need to know is that all of them have NS5As in them. So all of the drugs have NS5As. Only a couple have protease inhibitors, pretty much the Zepatir, Mavorite, and Vosevi. And then sofosbuvir is our NS5B. So anyway, that's just a little primer. Remember that they all have NS5As. We have 2 types of resistance in HepC that we talk about. We have resistance that's there at baseline. And by the way, this resistance, I'll just say the word resistance, but it's actually called resistance associated substitutions. I don't know why they need to make it fancier than the word resistant. But anyway, these RASs, you can have them at baseline, or you can have them emerge after treatment. That's the punchline. You can have them, you can select them out yourself, or they can be there de novo. Sofosbuvir, these mutations are not common. So you don't see a lot of those. The NS3, basically the protease inhibitor mutations, they can happen, but they tend to go away. The ones that tend to come and stay are the NS5As. So in general, we worry about NS5A mutations. And remember, there are those in almost all of our different drugs. What doesn't matter clinically? That's just, oh, and by the way, they're confusing. So how do I say this? This is NS5A Y93H. What does that mean? This refers to the protein. So we're talking about the NS5A target, and where you normally have a Y at amino acid 93, you now have an H. So you have a tyrosine instead of a histidine. I'm sorry, you have a histidine instead of a tyrosine. Do you need to know all that? No, but it helps demystify what the heck this gobbledygook of letters and numbers are. So anyway, what you need to know clinically is that if you're going to think about Epclusa and you have a genotype 3 cirrhotic patient, you need to do baseline NS5A polymorphism testing. So this particular patient would need baseline polymorphism testing. And what you're looking for in particular is this Y93H mutation. And that decreases your response rates to therapy from 97 to 84%. So that's why it's a big deal. So could you do that? Yeah, but you got to send out this Y93H NS5A RASS. That's like literally what you have to type in the order form to get it done. The other one you need to worry about is Zepatir. So Zepatir, you're also looking at the NS5A. And if you did order a genotype for resistance testing on NS5As, what you're looking for is a bunch of different results. But the punchline is they matter a lot. For genotype 1A patients, if you're going to use Zepatir and you have any of these mutants, that would decrease your response rates from 98 to 58%. So alternative regimen is suggested. That's all I have. And I just wanted to share that because I've had that thing forever. And so your patient, Mavorite, may be the easier side unless you want to do an extra blood test and look for that Y93H.
And this is Rachel. I'll just piggyback because you mentioned the drug interaction there with the loperamide. We have talked about that, so that awesome memory there, bringing that back up. But if he is truly only taking that PRN, I'm less concerned about that interaction with the Mavorite. With the loperamide, you always want to be careful with patients that have poor liver function anyways. But if he's only taking it every once in a while, I don't think that hinders you from, steering you from Mavorite to the Epclusa just because of that. And I don't have any concerns with his other medications. If you would go the Epclusa route, after, like Dr. Gofu said, doing that resistance testing, just be careful with his antacids. He'll just have to make sure he separates the Milcamag I see on there from the Epclusa by at least 4 hours, if you would go that route.
And one more thing on his case, if GI doesn't think he's like floridly cirrhotic and you've got that platelet count of 80, you could entertain at some point, not right now, but if GI is like, yeah, we don't think he's really cirrhotic, we don't understand why his platelets are so low, maybe get him over to hematology, because you can get ITP from HepC, because it just seems like aberrantly low platelet count for his level of cirrhosis.
Okay.
And 100% long-term HCC screening in him. You can't talk yourself out of that one over time. I should say I couldn't talk myself out of that one over time. I would give him Q6 months forever.
Okay.
Awesome find. Great case. Got me fired up. It's awesome. Good catch.
Thank you so much, John and Rachel, for, I love seeing you guys tag team on those recommendations. It's awesome. And love the 5-slide PowerPoint, Dr. Gilfus. So thank you for that as well. And Robin, did you have any other questions about your case that you wanted to maybe address with everyone?
I don't think so, but I have a random question about HepC patients that I've been meaning to ask, and you all might have already answered in one of the calls. But is everybody vaccinating for the PCV23 on all HepC patients?
So pneumococcal vaccination?
Are y'all? Is everybody?
Yeah.
Okay, just making sure that is required, and I thought it was, but I'm
It
just
is.
verifying.
Yeah. The weird ones that don't make sense are related to pulmonary pathogens. You're right on. So COVID and pneumovax should be part of the vaccines.
Awesome. Thank you for that question, Robin. All right, Dr. Bird, I'll pull up your case for you, and same thing. Anytime you're ready, just let me know when you'd like me to scroll up or down. But I'll turn things over to you now. Thank you.
Okay, thank you. So bear with me, this is my first time doing this. So this patient's a 47-year-old white male. Vitals are stable. He had no pain, no jaundice on exam. He started using IV drugs from around 2012. He was self-medicating for chronic back pain. He found out that he said 6 to 7 years ago. I looked back. It looks like he was originally diagnosed in September of 2013. He did pursue treatment, but he was still using heroin, and so his treatment was denied at that time. He was incarcerated from 2019 to 2021, and he has been clean since that time. He's been out for several months now, about 6 months. So comorbidities for him, he has anxiety, depression, chronic back pain, as I mentioned, and tobacco use. Medications include Buspar, Wellbutrin, gabapentin, and Flonase. He is immune to hepatitis A. His hepatitis B serologies were negative. He's been vaccinated prior, but we are in the process of vaccinating him again. BMI was 27.3. His labs, his CBC is within normal limits. His platelets were normal at 271. Kidney function is good. His creatinine was 0.84. His ALT and AST are mildly elevated. ALT was 103, AST is 72. His APRI was 0.7. His CTP was 6, MELD score 7. Vitamin D is 43.5. HIV is negative. He has genotype 1A. His viral load is 15,600,000. And his serum fibrosis biomarker was F0. So questions for him. I was just wondering if, since his fibrosis score is F0, his ALT and ALT are mildly elevated, does he need a liver ultrasound? And are there any drug interactions that we need to be concerned about? Again, for him, he's Medicaid, so thinking Mavorite or Epclusa.
Awesome. Thank you so much, Dr. Bird. And first of all, big shout out to you for your first awesome echo case presentation. So I just wanted to give you that shout out. Any clarifying questions about the case for Dr. Bird? Anyone is welcome to chime in.
I had a question. Just as you can educate me on this one, do you know what the gabapentin is for? In this
So I didn't prescribe the gabapentin. I looked back. It looked like originally it was for his chronic back pain that he has and anxiety. On his most recent note, it says it's just for anxiety. He does take 400 milligrams 3 times a day.
Perfect. Thank you. I forgot about the back pain part. Okay.
Any other clarifying questions from anyone? All right, and any recommendations, feedback for Dr. Bird? Dr. Gilfus, I see you.
Yeah, sure. Hey, great job. Beautifully done. And your conclusions are great. And actually, the question that you ask in it is the most pertinent one. And that's whether or not you need to even worry about an ultrasound. And in this scenario, I don't think you do. It's the preponderance of evidence says that this guy doesn't have anything going on in terms of major scar tissue. That APRI is super borderline, and I'm sure very, very dependent upon those transaminases, which you're going to normalize very quickly. So, if you recalculate his APRI in a month, that's going to be normal. It could be completely normal. And his serum biomarkers are already telling you that as well. So, yeah, I agree. He's just a treat, cure, and be done with it. So that's awesome. Yeah. And your treatment options for genotype 1A, this would be one of those scenarios where, you're as you mentioned, Medicaid's formulary is going to point you towards Mavorite or Epclusa, Mavorite 8 weeks, Epclusa 12. He would not be a short course Harvoni candidate in general because his viral load is too high. Remember, for genotype 1s, if your viral load is less than 6 million, you can contemplate 8 weeks of Harvoni, which is cool because it's one pill once a day in your non-cirrhotic patients, but it's not really pertinent because he has Medicaid and his viral load is too high. So it's greater than 6 million. And being a genotype 1A, the Zepatir would require that NS5A polymorphism testing if you were to be required to use Zepatir. But anyway, I think neither the Harvoni or Zepatir are an issue because he's got Medicaid. So go for it. Great job. You'll cure him and he'll be a happier, healthier 47-year-old with no need
Thank you
for
very much.
long-term stuff. Good job.
Thanks.
Thanks, Dr. Gilfus. Any other recommendations or feedback from the group? I know you had mentioned like drug interactions and stuff. I didn't know, Rachel, if you wanted to touch upon that or if there even was anything to mention, but I wanted to give you a chance to.
Sure. Yeah. Well, you're good to go with either regimen you would go with. No interactions expected there. The only thing to be aware of is checking his OTCs to make sure he's not doing anything acid suppressing if you would go the Epclusa route. And the only other question to ask him would be, as far as Maverick goes, it's a shorter course, but just making sure, he's aware that it's 3 pills and he's got to make sure they're with food. So if he's got a good routine where he's taking it with food, if he's not one to eat regularly, that might cause concern, but it's a shorter course if he goes the Maverick route. So, but you're good with his medications.
Okay, thank you.
Thanks so much, Rachel. And Dr. Bird, did you have any other questions about your case that you wanted to ask or?
No, I think they were all answered. Thank you all very much.
No, thank you so much. And thanks to all 3 of our case presenters. We really appreciate all of you guys. So we'll go ahead and turn to Victoria for your didactic. I'll be more than happy to pull it up on my end, but I'll turn things over to you. Just let me know when you'd like to go to the next slide.
Sure, that sounds great. Thank you very much. All right. Hi, everyone. My name is Tori Kaczynski. I am a PGY1 pharmacy resident at Allied Health Solutions Specialty Pharmacy, so working with Rachel over here. And today I'd like to talk to you a little bit about drug interactions, specifically drug interactions with our direct-acting antivirals that we're using in our HepC treatment. So we can go ahead and jump to the next slide to talk about our objectives. So our objectives today are to be able to identify common drug-drug interactions with Maverick, Harvoni, Epclusa, and Zepatir, and then to be able to recommend other options for some of these common drug-drug interactions that we might run into for some of these patients. And then at the bottom there, you can see a little graph. The red is for contraindicated, yellow for potential interaction or monitoring, and then green is for no interaction. And that'll play into some of the graphs that I have added into the rest of the presentation. And that will be throughout the presentation. We can go to the next slide. So first off, we'll talk about our acid suppressing agents. So first off, our proton pump inhibitors. So we want to be concerned here with the solubility of Harvoni and Epclusa. decreases as our pH increases. So when we're decreasing that stomach acid, becoming less acidic, we're decreasing the solubility of these DAAs. So we want to take that into consideration. So making sure we're watching that with our Harvoni and Epclusa. So watching those, and then if we go to the next slide, we can talk a little bit about our different options that we can have for our patients here. So with Harvoni, so it is recommended to use PPIs that are comparable to omeprazole 20 milligrams or lower. And this is for their total daily dosing. So if the patient is on omeprazole 20 milligrams twice daily, it will need to be reduced to omeprazole 20 milligrams once daily. And then our comparable options are esomeprazole 20 to 40 milligrams once daily, pantoprazole 40 milligrams for a total daily dose, and then lansoprazole 30 milligrams for a total daily dose. As far as Epclusa, it's a little bit different. So none of the other PPIs have been studied with it, but it is, if deemed medically necessary, we're going to be using, we'll have the patient take their Epclusa administered with food, and then 4 hours prior to taking omeprazole 20 milligrams. So just keeping those two in mind, those are our big ones for our proton pump inhibitors. And next we can talk about our H2RAs. Yep, thank you. All right, so with our histamine to H2 antagonists, we really want to be concerned again here with our Harvoni and Epclusa. So it is recommended to take our histamine H2 receptor antagonist simultaneously with our Harvoni or Epclusa, or 12 hours apart. So either together or 12 hours apart is the big kind of take-home message for our H2RAs. And then it needs to be a comparable dose to famotidine 40 milligrams twice daily, which could either be ranitidine 150 milligrams 4 times daily, or ranitidine 300 milligrams twice daily. And then lastly, we can jump to our antacids on the next slide. So antacids, again, Harvoni and Epclusa are our big ones. As Rachel mentioned earlier, we definitely want to be separating them by 4 hours from when the patient is taking either Harvoni or Epclusa. And with all of our acid suppressant agents, we just want to be concerned with, is it medically necessary for our patients? So if we can get away with discontinuing them while they're completing their HepC treatment, it would be in our best interest just to avoid drug interactions. But if medically necessary, we've talked about some of the different options here that we can do with our acid suppressing agents. Any questions about acid suppressing agents so far?
And Tori, I'll help monitor the chat if anything comes through the chat for you.
Sure, that sounds great. And we can jump to our next slide here. So anticonvulsants. So this slide might look a little scary. We've got red all across the board here. So what are we going to do with our patients who are on these medications? So honestly, with our best recommendations are to consult a neurologist. So if we pop to the next slide, we can talk a little bit more about our options. So once we consult neurology, they'll hopefully be able to facilitate our guidance on what different medications that we can change them to. If they do ask for recommendations, I've provided 4 here that actually don't interact with any of our DAAs. So lamotrigine, levetiracetam, valproate, and topiramate. So with this interaction, it's actually the decrease of concentration that leads to the reduced therapeutic effect of our DAA. So keeping that in mind for these, although it's a little intimidating that we have 4 right off the bat that are absolutely contraindicated, we do have other options for these patients. So we don't have to avoid therapy for them. All right, and then we can pop to our next slide. So anticoagulants and antiplatelets. The big one here to really highlight is dabigatran with Mavyret. So with dabigatran, it's actually not recommended, but if it is okay in patients who have good renal function. If a patient has between 30 and 50 milliliters per minute of creatinine clearance, we would want to actually administer a 75 milligram dose twice daily. So keeping that one in mind for dabigatran, and then not to administer it at all if their renal function is less than 30 milliliters per minute for our creatinine clearance as well. And then with all of these monitoring, we have a lot of yellow monitoring. So what does that mean? So we really just want to be monitoring for signs and symptoms of bleeding for our patients, and making sure they're watching out for any extra bruising, if they're having increased bleeding when they're brushing their teeth, or if they notice any blood in their stool, we want to make sure that they're noting that and letting their provider know. And then just watching out for toxicities as well. And then with warfarin, we do want to encourage INR monitoring is suggested. So continuing to do regular monitoring with our INR, and then even after treatment, just to make sure that we're going back to normal with our INR. All right, we can jump to our next slide with our birth controls. So our estrogen-containing birth controls, this is a big interaction with Mavyret. So although it does not affect our drug concentrations, it does increase our risk for ALT elevations. For different options that we can use, we can consider our progestin-only contraception, so the mini pill, which is norethindrone, our Depo-Provera shot, or the arm implant, which is the Nexplanon, or we have the progestin IUDs, Skyla, Mirena, or Lelita, and then the copper IUD, which is Paragard as well. So these are some good options, but our estrogen-containing birth controls pretty much make up all of our birth controls. So if you see anything on the packaging like ethinyl estradiol or EE, it is indicative of our estrogen. So we want to definitely avoid those in our Mavyret. If we jump to the next slide, I provided a couple of options here that we're looking at that would have that ethinyl estradiol in it. So but again, pretty much all of our birth controls that are on the market are going to be contraindicated with Mavyret because we have this estrogen in it. So just keeping that in mind, but we do have a lot of other safe options for our patients. So it's not just the mini pill that we would immediately jump to. There's a lot of other options that we can consider for them. All right, and then we can jump to our next slide. All right, so statins. We have a lot going on here with our statins. So we can see that Mavyret has a couple of absolutely contraindicated. So atorvastatin, lovastatin, and simvastatin, and then Harvoni with rosuvastatin is absolutely contraindicated. So we don't want to have our patients on either of these. To keep in mind, there are a lot of reductions in max doses that we can use with this, our orange yellowish color here. So with Mavyret on pravastatin, we're going to reduce their current dose by 50%. And then with rosuvastatin, their max dose is going to be 10 milligrams. And then if we jump over to Epclusa, there have been studies for the max dose of rosuvastatin being 10 milligrams. And then with Zepatier, we have our max dose of 20 milligrams for atorvastatin, fluvastatin, lovastatin, and simvastatin. And then rosuvastatin would be 10 milligrams for a max dose. Now I know this is a little confusing and can be kind of hard to remember. So I included all of our recommendations here just to be able to follow back on. Any questions so far on anything we've discussed? No? All right, we can jump to our next slide then. So our next one, we have amiodarone. So with amiodarone, it actually has not been studied in Mavyret or Zepatier, but it is contraindicated in Harvoni and Epclusa and can cause symptomatic bradycardia that can even lead to fatal cardiac arrest. So we also want to keep in mind the long half-life of amiodarone. So to be expected about 60 days half-life. So keeping that in mind, if we are discontinuing amiodarone right before we're starting therapy with Harvoni or Epclusa, we definitely want to continue monitoring our patients, their cardiac functions to make sure that they're doing all right and we're not having any bradycardia going on there. All right, and then we can pop to our next slide. All right, so our antiretrovirals. There is a lot going on here, and I would never expect you all to memorize any of these interactions because there are a ton. So my best recommendation for you all is to always refer to our hepatitis C guidelines. So I've included the link here that'll bring you right to the guidelines. So just keeping that in mind, if we're also treating our patients for HIV as well, we just want to make sure that we do a quick drug interaction to make sure that there's no other interactions and possible changes that we might need to make to their therapies. And then we can jump to our herbal supplements. So herbal supplements, as we can see, St. John's wort, we know, interacts with pretty much everything all the time. So again, here with our DAAs, we want to watch out. Shouldn't be administered with Mavorite, Harvoni, Epclusa, or Zepatier, because it is an enzyme inducer, so decreasing our concentration and leading to reduced therapeutic effects of our DAAs. And then common ones that we can see are milk thistle. Milk thistle is believed to be good for our liver health, so making sure if the patients are taking it, it's perfectly fine, as well as melatonin. So those ones are good. There are a lot of herbal supplements on the market, so doing a quick interaction check here with our herbal supplements is definitely recommended as well. And then we can jump to our next slide. So I just want to leave you all with a couple of pearls for today, just to make sure that we have some good information here. So there's no interactions with our COVID-19 vaccines, no interactions with cannabis or CBD, and then there's no interactions with our MAT medications. So all of our medications for our patients being treated with methadone, buprenorphine, or naltrexone. There's no interactions with any of our 4 drugs that we talked about today. And then also there's no interactions with grapefruit juice. That one gets brought up a lot, especially because there is an interaction with our statins and things like that. So making sure they're all good to go there on that grapefruit juice front. And then finally, just to leave you guys with some good resources, the University of Liverpool's HEB drug interactions checker website is absolutely awesome. So essentially you'll get to go on there and select your medication that you're wanting to look at, and then you can select all of the medications that your patient is on, and then on the right side it pops up all of the potential interactions. So if it's severe, and then if it's a moderate potential risk, or if it's good to go, there's no interactions. So with each of those, there are studies pulled directly through the information, so you can click on it for more information, and it is a really great resource. And there is actually an app that goes along with it, and it's a free app, so a really great resource for anyone on the go to be able to quickly look up a drug interaction for some of our HepC patients. And then last is my citation slide, and then what questions do you all have for me today?
Thank you so much, Tori. Also, huge shout out to you for your first ecodidactic presentation. You did awesome, and lots of great resources in there. So I'll absolutely attach your PowerPoint in the recap so everyone will have a copy of your slides. But yeah, any questions, comments, please do unmute and chime in to anyone.
Hi there, this is Julian Vidic. I just want to say, as a pharmacist, Tori and Rachel, for lack of a better word, you guys are the bomb. So it was just excellent. I really and truly, I mean, you know, this is our
Julian, it looks like your connection got.
will say so. Terrific. Thank you. Hello, can you hear me? Did you
Thank
guys
you very much.
Okay. Okay, I just want to say you guys are terrific. That's our wheelhouse.
Yes,
And,
thank you.
You know, just great. You know, pharmacy proud. How's that?
I love that. That's really nice of you, Julian. Pharmacy pride all the way. I agree with you. Any other shout outs, comments, questions from anyone?
Well, I was just going to comment that a lot of those alternative methods of birth control, the Nexplanon, the IUDs, those sorts of things, are available through the family planning programs at the health departments. So that may be a resource if your patient, you know, doesn't have coverage, thinks they don't have coverage for an IUD or something. That is a resource they can use.
Thank you so much, Dr. Extra. That's great. Anyone else with comments, questions?
And also in the future, does anybody have anything they would like us to cover from a drug interaction standpoint when we do this in the future that maybe we haven't included in the PowerPoint?
It's a great question, Rachel. We always love hearing from you guys, what you want to hear about, anything. So please do let us know. And you're welcome to think about it and email either myself or Elizabeth if you do think about it later on as well. So we'll pass it along to the hub members.
I was just going to go ahead and say that things like psych meds, because a lot of these people have comorbidities with mental health, and perhaps a separate presentation on that sort of thing would be in order.
That's great, Dr. Rexrode. I actually just chatted that to Elizabeth, so we'll take note of that for even second half of this year as a didactic. So thank you. That's very helpful. Any other comments, questions from the group? Well, Tori, you did an awesome job. That's why there are no questions. So that's kudos to you. I'm sure if anyone comes up with questions later on, they'll email us and we'll be sure to send it your way. All right. Well,
Thank you.
of course. Yeah, no, thank you so much. We really appreciate you. And thank you all so much, as always, for joining the sessions. We really appreciate each and every one of you guys. So I'll give you all about 10 minutes back to your day. The only announcement that I have is that our next session will be on May 12th, and Carolyn Kidd will be presenting on pronouns. So keep an eye out for that reminder, and we hope to see you all again next time. Thanks, guys.
Thank you.
Take care.